Okay, I think we might be ready to start probably. So good afternoon once more. Thank you for joining us in this online roundup celebration of the monitoring. I am Rafaela Rigoni. I'm the head of research at Correlation, the European Harm Reduction Network, and I'm pleased to chair this webinar today, where we will discuss the core reports of our civil society-led monitoring of harm reduction in Europe for 2023. So first, I will give you a brief overview of the monitoring and its contributors, and then I will invite our panelists to share their insights with us on the different harm reduction teams they worked on. We will also have time for questions at the end, but you are already all invited to type your questions in the Q&A box that you see below at any moment and interact with each other and everyone to say hello in the chat when you feel like it. I will go back to that and how it works in a moment if you have any doubts. And for now, I just want to share with you. I hope you can see it. Let me know if not. So let's go for a very brief intro of the monitoring. So our civil society-led monitoring of harm reduction in Europe is a collective effort that we use to map the development of harm reduction policies and programs in Europe, both regarding their implementation and the gaps and inequalities that persist. At Correlation, we are committed to improving the quality of life of people who use drugs and fostering social justice. And access to sufficient, welcoming, and good quality harm reduction services is a good part of this and essential to achieve this aim of improving quality of life of people. So to do that, we monitor also different areas, and our core monitoring involves the reports discussed here today. So these are discussing the availability, accessibility, acceptability, and quality of essential harm reduction services, the hepatitis C continuum of care for people who inject drugs, and the developments around new drug trends in different cities in Europe and from different perspectives. So one looking into drug checking services and samples that come from there, and another one looking into qualitative information via focus group discussions with service providers, experts, and clients of harm reduction services, among others. And all this data we use to inform and advocate for better policies, also to search for more targeted and sufficient funding, and seek to improve harm reduction planning and delivery. So here you can see our focal points. This monitoring is a collective effort and counts on the crucial support of our focal points. We have 42 focal points in diverse European cities. You can see them all in the slide and the reports that they have contributed to in 2023. And our focal points, they collect data based in their cities, based on their vast expertise in the field and their network in their region. So they are all members and special members with this special take. And together with the monitoring team at Correlation, the focal points also co-create the methodology we use for the monitoring and contribute to decide on topics we cover, the formatting of reports, and how we should do the dissemination. Since 2023, we also have counted on a partnership with TEDI, the Trans-European Drug Information Network. And via the TEDI members running drug checking services in different European cities, which you can see in this figure, the network collects data on new drug trends in Europe. So this data complements the one collected via Correlation focal points to have a more comprehensive perspective on the substances available in the market, their composition, and their potential danger for people using them. So let's go into the juicy part of the webinar, which is to hear from our panelists about the results they got during the monitoring and the consequences of these results for the harm reduction field. So I would like to invite our panelists to join us. If you can come in, and I would like to briefly introduce, so welcome. So we have Iga is a senior researcher at Correlation and an associate at Corvinus University. She has worked for harm reduction NGOs for over 10 years and has been part of the youth movement in harm reduction, and is the main author of the report on essential harm reduction services. Tuukka Tami is a research program director at the Finnish Institute for Health and Welfare. He has more than 20 years of experience in the drug policy research and development field, both nationally and internationally. And since 2018, Tuukka has worked closely with Correlation on monitoring civil society-based harm reduction in Europe. And he's also chair of a CERN Scientific Advisory Board. And Tuukka is the main author of the Hepatitis C report. Daan van der Gouwen is a sociologist working as a drug researcher with Utrecht-based Trimbos Institute since 2005, and is involved in many international projects targeting harm and demand reduction and evaluation of policies. He's also coordinating the Dutch Harm Reduction Network and the steering committee, part of the steering committee of Correlation, and is the main author of the New Drug Trends publication with focus group discussions. And last but not least, Guy Jones is a data manager for the TEDI network since 2018, ensuring compatibility of data from 20 different drug checking organizations, and to turn the real world data into clean data sets to track trends across the continent, nothing easy. And Guy is the main author of the 2 publications on new drug trends via drug checking data that we will talk about today. So welcome. And before we start, just for the participants, I would like to remind you that after the panel discussion, we will open for questions, but if you don't need to wait until the end, you can put your questions already in the Q&A box, and the panelists can already answer some of them in writing. And I see some of you are already saying hello in the chat. Just make sure when you check with whom you want to talk, so you can talk to host and panelists only or to everyone. Make sure to select what is your favorite option. And so let's get the panel expertise in the house. So to start, I would like just to ask you around if you could talk a bit about what are the main developments that you saw in harm reduction in Europe, considering the area that your report covers. If you can elaborate on any positive developments you have seen and still disparities, inequalities that persist. Please go ahead.
Maybe I'll go first. So the TEDI network has been consistently expanding over the last 5 years, and we continue to add more organizations to the drug checking, the kind of pool of organizations that are doing drug checking, which is really good. It expands our coverage in terms of countries and in terms of the demographics that we are reaching, and therefore the types of drugs that we get information about. However, at the same time that we are adding some more organizations, we are also seeing existing organizations facing challenges, especially in terms of funding, whereby they may be able to test fewer samples each year, and are maybe having to think really carefully about how they allocate resources. And so there's kind of a duality here. We're gaining many newer services with small testing operations, but we are losing some of the proportion of samples that can be coming from existing larger organizations.
Thank you, Guy. Maybe Dan, do you see anything related to new drug trends to continue on that perspective?
Well, I've seen a number of developments with new drug trends, which are similar and in line with EMCDDA, for instance, UNODC. So it's not specific about harm reduction services, rather than what they report, and they report a worrying situation. Actually, this is the core of my message today, is the appearance of nitazenes on the European soil. It's small scale still, but it's growing, and it's also really worrying. So it's not really an optimistic note to start with, but we need to say it. There's a increasing risk attached to nitazenes not being used as drugs of choice, but appearing in samples of heroin and benzodiazepines, for instance, in Wales, but also in the UK and in Ireland.
And that combined with the lack of drug checking services and lack of losing power of checking this substance is quite of a worrying perspective.
Exactly. So people they think they have ideas about what they're taking, but they have no idea what they're actually taking. So as Guy said, the number of drug checking services is increasing in Europe, but it still doesn't meet the demand in any way.
Yeah, and if I can chip in regarding that, also what we see in the context of essential harm reduction services is that drug consumption rooms are still very, very scarce across Europe. There are really just several countries where the network is well developed, like Germany, the Netherlands, maybe Spain, Switzerland. But to the east and east-south from Berlin, there is a huge wide stain on the map, and there are no drug consumption room, and drug checking services are not present in these countries in terms of proper drug checking with the laboratory equipment. I'm not talking about the colorimetric reagents now. That's another story. But yeah, so in this context, I would say that what we see in the landscape of harm reduction in Europe is also even more worrisome. That might make the situation even more worrisome if we are talking about preparedness for the possible synthetic opioid flood crisis, however we call it.
And if I may ask also Dan and Guy, based on that, this sort of divide between having drug checking and drug consumption rooms in certain countries and not having it on other countries, what do you see would be the missing links here? What do we need for these services to be developed also in the other areas?
Let me start, and then Guy can finish it properly. What is needed is a commitment from local authorities and national authorities. Drug checking is an evidence-based intervention, and when it comes to harm reduction and to monitoring drug markets, it's really very effective. But many countries, also at national level, they still have all these how to say. They don't really know what drug checking is, and they think drug checking is all about promoting drug use, which is not at all the case. Drug checking is an essential tool when it comes to warn about things that appear on the market, even more so than official things at the moment. So it's commitment basically, and funding is not a big problem because it needs some funding, but it's basically commitment, I would say.
Yeah, I think you can run, the perspective in the UK is that a drug checking service can be run for really quite a low cost compared to other services. And so the amounts of money that are required are not insurmountable. The challenge is the political willpower in the UK. Drug checking has become somewhat of a political issue, And that's the challenge that we face for our service. We are limited, and it is intended that we are to provide it for users who are dependent only. And so the government has put kind of restrictions on us to box us into that. And that makes it harder to reach a wide audience and gain trust of people and gain a critical mass and an economy of scale, because we're very limited in who the service is really useful for, even if anybody can, in theory, use the consultation part of the service.
And just a last, if I may, a last question, and then I wanted to move also to other services. What do you think, thinking about this, what you were saying, that so services are assisting certain groups of people who use drugs, but maybe not all. Could you talk a bit about how could potentially drug checking services and drug consumption rooms be integrated in a way that is possible that populations with using other sorts of substances or in more vulnerable ways can also have access to the services?
It's a good question, Rafaela. And actually, we're now in the process of getting our drug checking services closer to drug consumption rooms, as they do, for instance, in Spain already for quite some time. When it comes to nitazenes or other worrying substances appearing in drugs of choice, we know that people from marginalized communities do not often go to drug checking services because they are quite often dependent on a substance, and they don't want to. They just want the whole sample for usage and not getting rid of a bit for analysis. Now we go to drug consumption rooms and talk to these people. What do they need to have their drugs checked? And we've done it last week in some places, and it's actually quite hopeful how they are collaborating. And they see the need, they see the need to analyze the drugs, because even in the Netherlands, drugs are sometimes of very poor quality, and especially when it comes to heroin, and these services are needed. And when you talk about nitazenes and synthetic opioids in heroin, they really feel the idea and the need also to have the drugs checked. So I think it's a matter of time. We're doing this stuff now. We're improving our methods, basically.
I think there's a need in terms of making drug checking services accessible to vulnerable populations. There's a need to recognize and balance the trade-off between perfect accuracy of the analytical methods that are used against how long and how complex is the process for getting that result. If your samples can only be tested in a central laboratory that is 3 hours drive away, then there is a 0% chance that you can give a result back in 30 minutes. That's simple physics. There's no chemistry to it. And so thinking about how we make sure that there is some level of rapid response available to get results to people quickly, but also still making sure not to throw the baby out with the bathwater, and keeping a level of accuracy that makes sure that we don't have missing links in the analysis that end up exposing people to unexpected risk.
Thank you so much. So these are all areas that we need to improve and advocate for a rapid response and more integrated services. And before we were focusing on that, also Iga was talking about the disparities also in the availability of harm reduction services in Europe. And Iga, you wrote the report about essential harm reduction services. Can you tell us a bit about what have you seen in terms of development of availability, accessibility, quality of the services, and the differences you've seen?
Yes, so we have measured or assessed the availability of harm reduction services for the last couple of years, as basically the only aspect of them that was assessed over the last 5 years. Quality we've measured for the last 2 years, I believe, and now access and acceptability of services were introduced as categories of measurement last year for the first time. So there is no kind of temporal comparison possible. In terms of availability, very sadly, in general, we see a decrease in availability of services overall. Out of 15 services that we've addressed, 11 had deteriorated availability to, over between 2020 and 2023. The most deteriorating services included shelters and housing, opioid agonist treatment, but also needle and syringe programs. On the other hand, there are some positive developments as well. So since 2020, there was some more significant increase in the availability of prevention of sexual risks in the naloxone distribution and in the distribution of paraphernalia for safer nasal use. So these are the main trends. With respect to disparities, what I said already, so East versus West is definitely one of the main differences or kind of demarcations of different levels of availability, accessibility. Definitely there is the big differences between availability and accessibility of services outside in the community and in prison, despite they should be kind of counterparts and equal. Harm reduction in prisons pretty much does not exist in Europe overall, just in very short. And there are disparities in the reach out to different communities, to different subgroups of people who use drugs, with young people in prison setting, migrants without the legal rights to assistance, and LGBTQI community and people engaging in chemsex being the most underserved groups among those that we are addressing in our report. I think that's the main findings.
Thank you so much. Super comprehensive response, and I think picture for us to understand and think about what we need for the future. If you would think like what needs to be then further developed, what would you think in terms of policy or planning to better assist the different populations and to have more equality within Europe for services?
You know, I think it's a very difficult question because we have so many cities, we have so many different political contexts, and we have so many different needs of different subpopulations. I think that at the organizational level, what could be a good idea potentially is to join forces maybe with other organizations, non-governmental, local, national, international, that focus on certain subgroups that are intersecting with us, with drug use. So LGBTQI groups, young youth organizations, women's organizations, and so on, and maybe just try to join forces for a more powerful, effective advocacy, for improved political will and for improved recognition of the needs of these groups, and funding, because funding has been the main barrier to reach out to all of the populations basically that we've seen across years in our monitoring reports. And if there is political will, if there is funding, then I would say that the first kind of very tangible step would be to develop a proper needs assessments among these different groups in order to find out what really, so make the services and this entire process community driven really, as opposed to top down ordered. Yeah, I would say that that's the main problem here.
Really nice, thanks. And both the question of funding and integration of different services, I think, are common for what we were discussing before with new drug trends, and harm reduction services in a great way of addressing intersectionality and all the different issues that we have. And so I was wondering, Tuka, in hepatitis C, what have you seen, like in terms of the main developments, and have you also noticed these divides that Iga was talking about in terms of the presence of service and accessibility to care?
Yes, thanks. Definitely, and as we remember, hepatitis C section has been there from the very beginning of when correlation started the monitoring. So we have seen progress, but clearly we can also see that there are countries and cities, at least in two categories, with regard to progress in hepatitis elimination target. Some are able to maybe reach the World Health Organization's target by 2030, but many others will have a lot of difficulties in that. However, we can also say that after the difficult years of the pandemic, where harm reduction in general had to struggle with keeping services open and having wide enough access to the services, it seems, at least from the viewpoint of hepatitis monitoring, that now we are back on a better track. The positive development has been more or less re-established after the pandemic. So we have both good and bad news from the hepatitis C viewpoint, but as said, there's a divide between cities, at least to two or more categories with regard to progress.
Thanks. And where do you see where do you see the bottlenecks in terms of hepatitis for access? Because there is a lot of discussions, for instance, around community-based treatment and care versus more high threshold care. What do you see? What are the developments that you've noticed in terms of where people can get care? Where is that accessible? What are the major factors that hinder people to access care?
Well, I think very generally put, the main kind of strategic idea is to diversify as much as possible the hepatitis testing and treatment places where it's possible, and of course community-based and harm reduction-based testing especially, and contacting the ones in need is the key. And as I said, there's progress, limited progress on the simplification of care pathways and task shifting and improving community access, but we still need to do better, and especially in certain part of Europe and certain countries and cities. To mention, Iga said that harm reduction doesn't in practice exist in prisons, but for hepatitis testing and treatment, there has been progress. Prison has been increasingly also a place where this is possible, but not in a big extent, but still there's progress. So places like this, new places, also general practitioners and self-testing, and many possibilities are there. And I know that Mojca Matitic is also, among the audience, so maybe Mojca can also comment from her viewpoint about the progress in Europe.
Thank you, Tuka. And I think is a very interesting point, this, for instance, that in prisons we see indeed that testing for hepatitis, for HIV, this is where many times is a possibility of entrance for harm reduction inside prisons, is via helping to cope with the elimination of these communicable diseases. While in general, harm reduction in prisons, when it's not related to communicable diseases, is very hard to get a spot for organizations. So we have to take advantage of the different possibilities on how we can enter the different areas as well. And still, just a final question, maybe perhaps, unless Mocha has questions in the chat, I'm checking for hepatitis. Where do you see that are the main points that we should act now to improve access to people? Like, are we talking about more guidelines? Are we talking about different types of services, different policies, decreasing stigma around the disease? Or
Well, there are many things, of course, and again, different depending on the context we talk about. But we've had questions around on stigma for a couple of years already, and we can see that it exists in some places and in some services more than in others. So this is one thing to focus on, to work on those parts of the treatment healthcare system where the stigma is the strongest. So, because I think that stigma and the ideas around people who inject drugs is the key to change. Also, if we can do awareness raising and add information and so on, then also the services can get better, and harm reduction integration to the healthcare system becomes easier.
thanks. And I wanted to ask you all to talk about, if you would have to think about the main recommendations that came from the results of the reports you wrote, what would those be?
Maybe I can start. Two recommendations have already been mentioned. One is the expansion of drug checking services throughout the European territory. That's really needed. Another one is also to be more prepared than now for changing drug markets, especially the heroin markets, because nitazines we've talked about, but also another issue is the Taliban ban on the cultivation of opium in Afghanistan, which possibly will lead to a shortage soon in Europe, and a mixture of heroin with synthetic opioids. So these are two recommendations that I would like to address. And two others is that also through the work that we did, we saw that there's an increase in use of crack cocaine, methamphetamine, and other stimulants in Europe. So I would also like to recommend harm reduction services to have more attention, to pay more attention to people who use stimulants rather than heroin and stuff like that, because this is really needed. So think of crack pipes and other stuff to reduce harm for people who use these substances. And finally, also important, and this is a trend that has been experienced for a number of years now, is that more and more people turn online to source drugs, to buy drugs. And as a result, we as harm reduction services should not just only go in the streets and talk to drug users there, but also go online and do online outreach work. So these are the four recommendations I would like to present.
Thank you, Don. Super important to keep transforming harm reduction when the trends transform as well. So we have to keep up to date. Anyone would like to chip in?
I think I will maybe just add very quickly onto Dan's, because that is a fantastic summary from my perspective. It's very clear that there are some countries, and indeed entire regions of Europe, that have little to no drug checking provision whatsoever. And just as we were caught out as a society by COVID, I think there is the potential for us as a sector of people who perform harm reduction, there is a potential for us to get caught out by a major shift, something that comes along and really catches us unaware. And this could be the January 2020 that we exist in right now with regards to nitazines. And I think if we just have no visibility, as we do in some regions, then we really stand to get caught out by the potential for a change here.
Thanks, Kai.
Yeah, I think that I mean the regular or just you know, the usual recommendations that we have normally, scaling up all the services, making them more available geographically, covering more populations. These are kind of obvious things that we've been discussing for years now. But what I really would like to see, although maybe it's kind of like a utopian idea, it would be really great to see the mindset of the society and the policymakers to make harm reduction as a default response to drug use, not prevention, not law enforcement, but harm reduction as a really the default idea that is there, and that just accepts and acknowledges that that people will use drugs. You know, I don't want to repeat these cliches too much, but I think that it would be quite beautiful, and I would really like to see that when people think at some point drug use, the first thing that comes to their minds is harm reduction services and not the police. You know.
That's a very good summary of our dreams, our collective dreams, I think.
Well, I think that the cliches need to be repeated to some extent, not to be forgotten, because there's something behind them. And talking about scaling up and so on, this is actually what is needed also in hepatitis work, but in all harm reduction. But what you said about kind of mainstreaming harm reduction and also hepatitis C related work, that's I think it's a necessity, especially when we think more broader the future healthcare and social work personnel, the lack of them and lack of resources. We have that in most countries, that this is the future, that we don't have enough professionals. And in that game, I think harm reduction as a separate system run by NGOs mostly is not the winner. So the kind of one way to survive is to integrate more to general healthcare and other systems, not to be isolated totally, at least.
Thanks, Tuka and everyone. I see there are a few questions on the Q&A box already. Please put your questions in there. We are going to address them now, so don't be shy. Just put your questions there. Let me ask one here that is a more general question. It says that there have been great successes in opening drug consumption rooms in recent years, for instance, in Athens, in Lisbon, in Porto. However, there have been significant delays in other jurisdictions like Ireland, Scotland, that had years of delays in establishing medically supervised injection facilities. And the participant is asking for each panel member to say what they think is the single most important consideration in establishing this and other types of harm reduction services.
I'm not sure if I understand the question well. So the main single consideration, meaning the basic reason to set up consumption rooms, is that, if that's the question? No.
Drug consumption rooms and other services that are contagious, that are not super accepted by society. What is the most important thing? I understand in
I think it's
what
not
should
the why,
be the most
but
important
how.
consideration.
Oh, the how.
Yeah.
Okay, talking about the how of at least drug consumption rooms in the Netherlands, is that you need a broad consensus between, well, the people who use drugs, the communities of where a consumption room is going to be established, and local authorities. And you have to be very clear and transparent about what services you are providing, what you are doing, why you're doing, and how you're doing that. But it's essential that you need to be in contact with the residential area, the people living in the area, very close to the drug consumption rooms, in order to make it a success And once you have that contact, the success will most likely follow. This is at least the situation in the Netherlands. There's always a lot of rumor once people talk about, setting up a consumption room somewhere, but once actually it started and the neighborhood sees it has effect because the streets are empty again, children are safe, and so on to play in the streets. There's no litter, drug litter in the streets any longer. So people are in general very content with drug consumption rooms, but it takes effort and perseverance.
In some of our other works and consultations that we had this last year on drug consumption rooms, also we found out that a kind of trying to establish an alliance with the local law enforcement proved in many settings to be quite impactful and contributing to the success. In terms of course, the police would support, if they support existence or establishment of a DCR for different reasons than harm reduction organizations, probably. But this is something that apparently some organizations exploit, and though with different motivations, work for the same purpose, and that law enforcement as an ally is quite instrumental in enhancing the support of the local communities as well.
Anyone else would like to dip in?
Well, if we talk about drug consumption rooms and how to make them happen, we have been struggling with that question in Finland for 5 years now, because the problem is that it's the national level decision to change the law to make it possible. And in the first place, it was our capital, Helsinki, that suggested that we should experiment that. So this is the kind of trap. We are between local or regional or city level decision making and national level decision making, and the national level is always more kind of conservative and more less understandable for these kind of things. So I don't have an answer for you. I only have a remaining question.
It's a difficult question, and I guess if we would know the perfect answer, harm reduction services would be already overall. We're still trying to find out the best ways of doing it. I was wondering also the place of supportive legislation and policies for it might be also another thing that we could add, especially for certain types of harm reduction services. So there are other questions here. I see there is a question, there is more specific that Guy mentioned he wanted to answer live. So is a question that's about tested heroin sample for nitazines in Bristol, and if you can, Guy can tell us the technique that was used to test the sample, and if it was test strips or something else. Would you like to answer that one, Guy?
Yeah, at the moment, the service in Bristol is working in partnership with Bath University. So in the field, we are using the new nitazine strips. They have limitations. They do not detect all of the family of nitazine drugs, and this is already a fact that has been published by the manufacturer. And they have the sensitivity is not good enough to avoid false positives all the time. So they are not a perfect solution, but we have nothing better for ultra rapid high sensitivity analysis in the field. Once we have done that, we then are sending the samples off to Bath University, who are using GCMS to confirm or question the results from the strips, and so far we have not had any nitazene samples, or no, well, yes, no nitazene samples whatsoever in any of the samples that we've tested.
Thank you, Guy. There's another question that goes around drug testing, drug checking, and drug consumption rooms from Ben Collins. And he's asking, can you make any generalizations about drug testing and drug consumption rooms by those using opioids and those using stimulants? Do you see different patterns, levels of use?
Well, obviously, people who use stimulants, especially in chemsex areas, you know, they seem to continuously use needles, so they need much more needles than a heroin user would need. When it comes to cathinones or other MPSs, it's even worse. So you need a broad, not even the number of needles needed per session, but also the variety of syringes is it appears to be more broad what you need if you compare that to classic heroin injectors, for instance. So yeah, there's different patterns, different needs.
Thanks. Anyone else would like to say something? Otherwise, we have other question we have from Japan, saying Japan is a country with strict drug policies, and asking how do drug consumption rooms and drug checking services can protect against police arrests for illegal drugs. If you would have any examples of how the services can benefit service users from unwanted law enforcement attention.
Again, we have discussed it before. I think the legal framework should be adapted in such a way that, you know, the users of consumption rooms or the users of drug checking services are not being criminalized, of course, because when that happens, you can just stop functioning, you know, those services because it will not work. So you need to protect the people who make use of the services. And we have done that in the Netherlands on various levels, because for drug checking services, it's different than for drug consumption rooms. But also the people who work in those facilities, they should be exempted from the law. We do, you know, when I do drug checking in the Netherlands, we have a permission to work with, to have all these illicit drugs on me, because otherwise I would be considered a drug dealer. But with this exemption, we just can't do the work. So you needs to have a proper and solid legal framework, to be short.
Yes, I think that not necessarily, I mean, decriminalization, of course, of use of possession is it is necessary. It's a big step. I think that there are possibilities of kind of smaller changes where there is political will. I think that if there is political will, even in the context which criminalized possession for personal use, there is a possibility of operating drug checking services, drug consumption rooms, as long as there is political will, because it's ultimately also the politicians, the ministers who give orders to the law enforcement agencies, to the police, and so on. There can be formal, informal agreements between the law enforcement and the services regarding, I don't know, abandoning the practices of stop and searching people in the vicinity of services, and so on and so on. So of course, the big changes in the legal framework, where everything is very clear legally, are an ideal solution. But I think that there can be kind of smaller scale solutions as well that can work until this bigger or higher level changes are achieved.
Sure,
and
you have
probably
this.
also
You know,
easier to implement on local level.
no, I agree with you, Iga. But you know, I just mentioned that because, you know, when you want to have a sustainable harm reduction service, such as a drug consumption or drug checking services, you need changes in the legal framework.
Sure.
But of course, to get there, you may want to do some small steps first. Sure.
So this is
Thanks.
the journey that the loop has been on in the UK over the last sort of 8 years. And we are now, there is still no law permitting drug checking specifically. There is still no decriminalization of possession, so we are still on this path. When we first started, it was through agreements with local police forces, and we would write up a memorandum of understanding laying out what each organization would be able to expect from the other. And of course, prior to that, it was really important to make sure that there was open dialogue about, you know, these are the benefits of being able to run this drug checking service. We can reduce the pressure on hospitals when we are operating at the festival. And so getting the police to understand that was the step to having the memorandum of understanding. Then we were able to start building up some evidence from within the UK. And that allowed us to go to the government and apply for a formal license to handle drugs. And they initially just rejected this, and so, you know, we have been then continually fighting to get this license. Now we have it, but yeah, we are still, essentially we are working towards this better framework where the drug checking service is legal and it is within the regulations, and that there are formal protections written down for people using the service. Because if you would have one person arrested inside of the drug checking service, forget it, it's closed. So it really needs to be done carefully, but I do think there is an important place for negotiating at a local level directly with the police and directly with local politicians.
Thanks, Guy. I think that already answers at least partially the question from Dimitris in the chat, but I will put the question here anyway, and please feel free to add. Dimitris is saying that in Greece, they are the only organization, Generation Act, with drug checking services on site on party festivals, but it is a gray area regarding the law. And the advocacy is difficult for small organizations like them. How can we have an advocacy of bigger scale, asks Dimitris.
I think something that worked really well for us and worked in our favor was to start building up data from the samples that we were analyzing over the course of one summer, 8 festivals, and then the next summer and the next summer, and be able to start showing this is what we're detecting. This is what happens when we tell somebody your drug is not what you expected it to be. And indeed, we see a huge number of people just throwing it in the bin as a result of that, or in the secure destruction container. And then having built that up, we could then go to authority figures and present them with this. And it's a lot harder to deny the effectiveness of something that has a, you know, published research behind it, saying this is what we've been doing, this is the impact that it is having, and we need your help to expand this impact and make it available to more people. I think that was, yes, really, really valuable. So yeah, make sure that you're collecting information and organizing it and then presenting it well to strengthen your case.
And to add to that, you know, many drug checking services are on the forefront of early warning. And since we have this drug checking in a number of countries, we can early detect extra dangerous substances on the market. And as a result, since we are in close contact with the people who use drugs, we're also we can rapidly address those substances on the market and warn. And as a result, perhaps even we can get extra dangerous drugs off the market quickly, because it becomes unsellable once you are going to warn for a very specific tablet with a specific logo, specific color, and so on. Nobody wants to have that. You know? So, yeah.
Thanks, everyone. I think we are almost arriving at the end. I don't see other questions at the moment, unless they are somewhere in the chat, but then please put them in the Q&A. Yes, Iga?
Yeah, I would just kind of to complement what Guy and Dan said. Yes, evidence, but not only. If evidence-informed policymaking was the reality of our society and politics, there would have been harm reduction everywhere already. It's not. There are political interests, there are emotions involved, especially in such a contentious topic that are very much morality related for a lot of people in the society. So yeah, I think that using emotions referring to experiences, trying to be relatable to as many people as it's possible, and also sadly using crisis situations, because many governments are very reactive instead of proactive. This is very concerning in the context of nitazines and other synthetic opioids. But you know, if you can just talk and kind of get to them through their considerations, like their children going to music festivals and so on and so on. This is also an important angle to implement, I think, besides next to evidence.
Thanks. Very important. This two fronts of fight for more harm reduction and better quality of life of people who use drugs. I wanted to ask. I want to share just for everyone who is in the webinar. If you allow me, I just wanted to share the QR codes for all the reports we are discussing here, the essential harm reduction services, hepatitis, new drug trends, and also an executive summary that we have putting all our reports together. So please feel free to connect with that. We will have translated executive summaries in 10 different languages. These are coming in the next few weeks. So keep track of our website and links for that. And I would like to ask the panelists to see if they have any last remark they would like to share with us. Any last words?
Thanks, Rafaela, for chairing and coordinating our style, because we all have black shirts and the chair has a colorful one.
Everyone received the memo, which we never sent, but it's really interesting. All right, then we end up in this stylish remark. Thanks a lot for the panel, for your super contributions and your excellent work in writing the reports. Thanks a lot for everyone participating and here with us. And we will share the recordings of the webinar later on in our website and socials. So keep track. If you have any questions after the webinar, please feel free to reach out to us, and we'll do our best to keep in touch. Thank you so much, and enjoy the rest of the afternoon.
Thanks.